Hello everyone and welcome to Teach It Forward Thursday in the Neuro-Ophthalmology Clinic. So today's case is a 55-year-old woman whom I've been seeing since 2012, so 9 years ago is when she first came to see me. When she first came in, she'd already had 2 brain surgeries, and we're going to get to what those surgeries were. But when she came to see me, she had decreased vision, more in the left eye than the right eye. She was 20/20 on the right, count fingers on the left. Her colors were decreased. A little bit on the right, more so on the left. She had a field defect, which I'm going to show you, and a pale optic nerve on the left. So I'm going to show you what her fields look like, and I want you to try to localize this lesion. Where do you think this lesion goes? Her visual field is quite interesting. So in the right eye, it shows that she has a dense temporal defect that's obeying the vertical midline. And in the left eye, she has a complete blackout. So basically with count fingers vision, she's not making out anything in her field. So where does this localize? Well, the fact that the right eye obeys the vertical midline, it's a temporal defect, tells you that this defect is caused by something either at the chiasm or behind the chiasm. And I didn't tell you this, but she also had a relative afferent defect in the left eye. So this suggests that this may be at the anterior part of the chiasm, perhaps a junctional scotoma. So next I'm going to ask you, what diagnosis do you think, what lesion do you think could be causing something at the chiasm or the anterior part of the chiasm to cause a junctional scotoma? So take my quiz. This is the earliest MRI I have on the patient going back to 2012, and this is a coronal post-contrast study. And as we go back, you start to see that there's this enhancement here, and it's a little bit heterogeneous. There are some areas that are brighter, some areas that are darker, and then there's kind of a rim of enhancement around it. And it extends not just in the cellar region, but it extends into her sinuses and further back into the brain, mainly on the left side. And then just going back here, you can see here in the ventricles also there's some very, very bright signal here suggesting that there is some extension of the lesion or perhaps rupture of the lesion causing some ventriculitis. And then I'm going to also show you her sagittal. So again, this is the same scan, and you can see that again, it's a pretty large lesion, cystic, perhaps lobulated, heterogeneous. You can't even really make out where the chiasm is in here. Really interesting scan. So based on the characteristics of this neuroimaging and the location, this lesion was most likely a dermoid cyst. So a dermoid cyst is usually congenital. It's pretty uncommon, less than 1% of intracranial tumors. And if you remember back to your embryology, this is ectoderm. So there is epithelium, there are there's glandular epithelium, and some dermoid cysts even have teeth and hair within them. And so these cysts, they can grow over time, and usually if they remain encapsulated, they're usually pretty benign, but sometimes they can rupture and cause very significant inflammation. There are fat globules that spread and they cause a lot of inflammation, so basically a sterile meningitis. So this is what the patient ended up having back when she was first diagnosed. She had 2 craniotomies, so she had excision of the lesion, but it kept growing, and what happened was it continued to have inflammation. At one point she even had a brain abscess due to all this inflammation. I'll show you what that looked like. And it ended up that she ended up having 4 craniotomies for this problem, and it still did not control her issue. She continued to have inflammation and the lesion kept continuing to grow. Then she had 2 transsphenoidal surgeries as well, and even despite that, it continued to grow. Now after her 4th craniotomy though, she actually lost more vision. So the right eye was 20/20, it went down to about 20/30. She had worse field deficit. The left eye actually went down to low light perception. So unfortunately she lost quite a bit of vision after that 4th surgery when she had the brain abscess. So in March of 2015, the patient was not doing so well. She actually became quite lethargic and she developed a fever. She ended up being hospitalized and had a scan. And I want to show you what that scan looked like. So you can see she's got significant hydrocephalus. She has a pretty large fluid cavity here in the right frontal lobe, and then this area of enhancement in the left frontal lobe. And let's see as we keep going here. And then she's got all of this enhancement here. in the area of the dermoid. It ended up that she actually had an abscess. So this area had gotten infected with methicillin-sensitive Staph aureus. I'm not sure exactly where she got it from, perhaps from her sinuses. She ended up needing an emergency bifrontal craniotomy and subsequent transsphenoidal hypophysectomy to try to remove some of the abscess and debulk the tumor. And more recently, on a recent scan, she started to have, again, some increased signal, more heterogeneity, and this was just done for routine purposes. She wasn't really having any symptoms, and she does have, again, the area here, the dermoid cyst, the residual cyst, and it was slightly more heterogeneous and more enhancing than the prior scan, and even though its size may not be that much different, it was decided that she would benefit from surgery. So now she is scheduled to have her 7th brain surgery later this month. She's going to have another transsphenoidal surgery to try to debulk this lesion. After surgery, there is a consideration to give her radiation therapy as well to prevent this benign cystic lesion from growing again. But unfortunately, the patient has a very limited field, and hopefully she does well after the surgery and potentially radiation. She basically has one quadrant that she sees out of the superior nasal quadrant in the right eye that she's seeing out of right now. Otherwise, she's doing relatively well, no headaches. She did have a couple of seizures, but now they're better controlled with Keppra. And we will keep our fingers crossed that she does well after her 7th brain surgery. So anyway, a case of an intracranial dermoid cyst, staph plus rupture that caused a chemical meningitis, and a brain abscess that keeps growing that is requiring 7 brain surgeries. Not good, but we will pray for this woman and hope that she does well. And anyway, I hope you enjoyed today's case. If you have any questions, please post them below, and I look forward to seeing you all next week.